to welcome you to today's webinar, Thrombosis and COVID-19, Canadian Expert Perspective. I'm Alan Bell. I'm Vice President of Thrombosis Canada and Assistant Professor of Family Medicine at the University of Toronto. Before we begin, I'd like to acknowledge the dedication and courage of not only healthcare professionals, but all of those who are putting themselves in harm's way to help fight against this pandemic. I want to point out that the content of this program was developed entirely by this afternoon's faculty based upon their review of the latest evidence of thrombosis and COVID-19. And when I say the latest evidence, I mean up until today. We will start with a short presentation by our 6 faculty members and then respond to as many questions as possible. So I want to acknowledge our planning faculty that you can see on the screen here today, both primary care physicians as well as specialists in thrombosis and hematology. These are our disclosures. I'm not going to go through them all individually. There has been commercial support for this program, and we would like to acknowledge and thank the following organizations: Bayer Canada, BMS Pfizer Alliance, Leo Pharma, Novartis Pharmaceuticals Canada, Pfizer Canada, and Servier Canada. No members of any of these commercial organizations have been in contact with any of the speakers directly, nor have they been privy to any discussions surrounding the content of this program. As I pointed out, the faculty has created all of these slides completely on their own and are based on the current evidence that is available. Our objectives today are to incorporate the latest information about thrombosis and COVID-19 into clinical practice, to effectively manage anticoagulants and thrombosis remotely, and I will point out that that is unrelated to COVID-19 disease, but related to certainly the altered practices that we are all facing in this pandemic, and to discuss the hematologic coagulopathic issues that are evolving around COVID-19. We're trying to aim this for as many of our specialties as possible in this program. Our agenda today will look at a primary care, internist, hematologic, and emergency room perspectives, followed by a question period. So from my perspective as a family physician, I would like to discuss a few things. So for all the family docs and specialists out there, I think that we'll recognize that we've had a huge challenge since COVID-19 has come along, which has completely redefined the provision of primary care. My office is unrecognizable from what it would be a month ago or 3 weeks ago. We have no waiting room. We see patients one at a time. Virtually almost all of our visits are being done virtually, mostly by telephone, which precludes the use of physical examination, which are clearly helpful for the diagnosis and management of venous thromboembolic disorders, as well as cardiac disorders requiring anticoagulation. We really don't have the same kind of consideration for the use of emergency rooms, considering that they are under such an increased burden or potentially increased burden due to the COVID-19 pandemic, as well as being a potential source of exposure to our patients. So we're very much trying to keep them out of not just the emergency rooms, but the hospitals in general. INR monitoring for patients who require it also potentially exposes them to COVID-19, and we will be discussing issues around how that can be managed. And COVID-19 itself, of course, is associated with thrombotic and bleeding complications that primary care physicians are certainly going to have to be aware of. Now, I'm not going to make any attempt to try to direct primary care physicians how to deal with all of these issues, but what I would like to do is simply point out how hard Thrombosis Canada has worked over the years to provide as much support as possible to my colleagues in primary care. Our vision at Thrombosis Canada is to be the voice of thrombosis medicine, which we have been for almost 3 decades now. And we believe that this is best accomplished in our primary targets of primary care physicians by providing point of care guidance, which are founded on national and international guidelines. And we continue with this mandate to assist healthcare professionals with this pandemic. We do that through our use of clinical guides, which are available to all of you online as well as on your app, with the use of tools that provide guidance in the management of acute venous thromboembolism, as well as atrial fibrillation. Tools that will assist you in very much in managing your patients with thrombotic diseases, including atrial fibrillation, bleeding management, DVT, pulmonary embolism, anticoagulant perioperative management, anticoagulant dosing. I think this is more important than ever in the presence of COVID-19. And we have now got an area that is specifically dedicated to thrombotic issues in COVID-19 on our webpage. Of course, we will continue to provide seminars like this one. We will be repeating this seminar in 2 weeks' time, probably with updated information. I would like to turn it over at this time to my colleague, Jim Duquetis. Most of you know Jim. He is a professor of hematology and thromboembolism in the Department of Medicine at McMaster University. He is a world-renowned expert on thrombotic diseases, and will talk to you about the internal medicine issues specific to COVID-19 infection. Jim?
Thank you very much, Alan, and good afternoon, everyone. As Alan said, there are different perspectives that will be provided this afternoon for you, and I will provide the perspective of an internist or a hospitalist dealing with this disease. I think we're familiar with the epidemiology and the etiology of COVID-19. And here I provide you with just some website areas that you can look at to address the current epidemiology and the etiology, as you know. In terms of where we're at and regarding the known pathogenesis, this is information that I think is fairly common knowledge, but provide a review for you. And essentially what you'll see is, in response to the viral antigens, you get a very aggressive, in some cases, immune response, leading to what's referred to as the cytokine release syndrome and the associated manifestations. There is information here about the incubation period and the contagious period that, again, we are fairly familiar with. It's thought that most patients will develop symptoms 4 to 5 days after the exposure. The next slide talks about the diagnosis, the detection of the genetic material, and the clinical and radiologic features. As you can see there, some of the X-ray features indicative of an interstitial pattern on plain X-ray and a ground glass appearance on a CT scan. There are other conditions that should be included in the differential diagnosis. And I should point out that there's no way to distinguish COVID-19 from other respiratory viral syndromes. And finally, in terms of treatment, there are a variety of treatments that are being intensely investigated currently. As you'll see on this slide, on the next slide, none of these treatments have been approved for clinical use by Health Canada, and some are approved in other jurisdictions on an emergency release basis. The treatment currently is supportive, as you can see here, and to emphasize that glucocorticoids are not indicated, as are antibiotics also are not, unless there's a bacterial superinfection suspected. And the final slide just shows the array of treatments that are, again, under very intense investigation. So with that, I'm going to turn it over now, and we'll focus on the thrombotic and coagulopathic aspects of this disease.
So our next speaker is Eric Sang. Eric is a hematologist, staff hematologist at St. Michael's Hospital in Toronto, Ontario. He's an assistant professor in the Division of Hematology and Oncology at the University of Toronto.
Thanks, Alan. So I appreciate you all joining us today on a Good Friday, although under these circumstances. As a hematologist, I'm going to be focusing on some of the coagulation issues, and there's a lot of emerging data that's come out just in the past week or two about this. By the end of my 10 or 15 minutes, there's three main messages I'd like to communicate to you all today. The first is that severe COVID infection appears to be a hypercoagulable state. That being said, the prevalence of acute VTE in this group of patients remains uncertain, particularly relative to other critically ill patients or patients who have acute respiratory distress syndrome outside of COVID. Secondly, elevations in D-dimer are frequently seen in COVID-19, and there is an association with mortality, and this may reflect either the underlying pro-inflammatory state or the hypercoagulability that we have been seeing. And thirdly, this is probably the most germane recommendation that may change in the near future depending on data. All admitted COVID patients should receive standard weight-adjusted VTE prophylaxis. However, at this time, there are insufficient data to recommend intensified empiric prophylaxis regimens for patients who have a high D-dimer, mechanical ventilation outside of the clinical trial setting. So we'll delve into these aspects today and some of the data and rationale behind these messages. So just a little bit about the common hematology abnormalities that we see in COVID-19. So on the left are your hematology parameters. In the middle are the typical trends that have been reported in COVID-19, and then on the right is the clinical impact that we know of so far. So the first is thrombocytopenia. So 20 to 30% of patients who have COVID-19 will have thrombocytopenia, but unlike other forms of sepsis, bacterial sepsis, for example, this tends to be in the mild to moderate range, typically with platelets in the 100 to 150 range, and there doesn't appear to be a clear association with mortality. It's been widely reported that lymphopenia is a common feature in COVID-19, with up to 80% of people having a mild lymphopenia with an absolute lymphocyte count of less than 1.5. However, the severe lymphopenia that we see with an ALC of less than 0.5 is often seen in patients who have developed critical illness in the ICU, for example. The prothrombin time, the PT, is often mildly prolonged in this condition. So we're seeing prolongations generally 1, 2, 3 seconds, and there is some association with mortality. There's been a lot of focus on the D-dimer as well, and we, in a large percentage of patients, and we'll talk about this on the next slide, a percentage of them will have persistent, often marked elevations in the D-dimer concentration in severe COVID, and this is also prognostic and has been associated with mortality in this illness. Finally, the fibrinogen. So, as you know, the fibrinogen is typically depressed in most forms of disseminated intravascular coagulation. With COVID-19, we're typically seeing elevations of fibrinogen, and the reductions have been happening late in the disease course, often 10 to 14 days into admission in patients who have advanced disease. So it's becoming clear that the coagulopathy of COVID-19 does have features of disseminated intravascular coagulation, or DIC. On the left is a table of coagulation parameters for patients who were admitted in Wuhan with COVID-19. And the yellow bars are statistically significant differences in coagulation parameters. And on the left are the parameters, and then you've got survivors and non-survivors in this small study of 180 patients. You're seeing here that there is a slight significant prolongation in prothrombin time between survivors and non-survivors. And in D-dimer concentration in particular, we are also seeing a statistically significant increase in mean D-dimer concentrations in patients who are non-survivors. As we mentioned before, with the fibrinogen concentration in most individuals, it tends to be in the normal or elevated range. If we delve into this a bit further, if you look at the clinical course of patients, so on the top right is D-dimer concentrations in patients who are survivors versus non-survivors. The non-survivors are patients in green, and in blue are the survivors. And you're seeing that on the x-axis is days into admission, and then throughout the hospitalization, the patients who have been non-survivors have seen an increase in their D-dimer concentrations, often quite markedly so. With fibrinogen, as we mentioned on the bottom graph here, there's not much separation between the survivors and non-survivors until late in the clinical course, 10 to 14 days, when we're starting to see the fibrinogen decreasing as the DIC progresses. Another study from Wuhan, published in the New England Journal of Medicine, looked at 1,100 patients with COVID-19, and they found that amongst all presentations with COVID-19, not all of whom were critically ill, 46% of patients in total had an elevated D-dimer on presentation. Amongst the patients among this group who ended up in the ICU or intubated, 70% also had an elevated D-dimer as well. However, it remains unclear whether the high D-dimers in COVID-19 are reflective of the hypercoagulable state or simply a feature of the pro-inflammatory state that we see with SIRS and ARDS with this disease. Because as you know, the D-dimer is a non-specific acute phase reactant, and it will be elevated in general in other causes of systemic inflammatory response syndrome or sepsis. As an example, this is a study that was published also from Wuhan, looking at 450 patients who had COVID pneumonia, compared with 100 patients at the same time who were admitted for non-COVID related pneumonia. And we're seeing here that the D-dimer at the bottom here is elevated in both groups. So we're seeing elevations due to not necessarily COVID itself, but due to the inflammatory response seen in patients who are ill and admitted to hospital. That being said, it's becoming apparent based on emerging data that severe COVID is likely a hypercoagulable state that is marked by high D-dimer levels and high fibrinogen concentrations, at least initially in the disease course. There are limited pathologic studies suggesting that in the pulmonary microvasculature, there is an increase in microvascular thrombosis, although these are limited to small case reports, autopsy/biopsy studies, and there's a theory that this may play a role in the progressive respiratory failure that's seen in these patients. There's also early data suggesting higher rates of VTE in the absence of pharmacological prophylaxis in patients with COVID-19. This is a study from Luo et al. This has been widely cited actually, this was a lung biopsy of a patient who had COVID pneumonia, just published online. And when they took this sample of the lung biopsy, they found that this patient had evidence of pulmonary interstitial fibrosis, pulmonary infarction, along with small vessel hyperplasia, luminal stenosis, and microthrombosis. Again, there are challenges with interpreting this and generalizing this to other groups of patients, particularly other patients with acute respiratory distress syndrome, not in relation to COVID. This is another study that was just published last night in the Journal of Thrombosis and Hemostasis from Wuhan. This was 81 ICU COVID patients who were admitted. None of these patients received pharmacological prophylaxis in the ICU, and these patients were screened with leg ultrasounds and D-dimers. They also had a standard not CT chest, but not a CT pulmonary angiogram. The key finding from this study, in these patients who did not have pharmacologic prophylaxis, 25% of them had lower extremity DVT. In terms of the D-dimer cutoffs that were examined, when they looked at a D-dimer of 1.5 micrograms per milliliter, these were the test characteristics in terms of sensitivity, specificity, and negative predictive value for DVT. This is another study that was just published this morning, actually, from the Netherlands. And this preliminary data suggests perhaps higher VTE rates in ICU hospitalized patients with COVID, despite standard pharmacological prophylaxis. This was a study in 3 Dutch hospitals, 184 patients. Many of these patients are actually still admitted to hospital or in the ICU in these hospitals. Amongst these 184 patients, 38% had evidence of prolonged prothrombin time or APTT, so they had coagulopathy. 13% were on dialysis, 9% were receiving therapeutic anticoagulation, likely for different indications, and 3% had active cancer. Unlike the previous study without prophylaxis, in this study, these patients did not receive screening ultrasounds. The imaging was triggered by clinical suspicion alone. This was the prophylaxis regimen that was used in this study. So amongst the three hospitals, most patients received at the beginning of the study standard low molecular weight heparin low-dose prophylaxis. So they used nadropirin there at a dose of 2,850 units daily. A priori, patients with a weight above 100 kilograms had a higher weight-adjusted dose of double that, so 5,700 units daily. However, partway into this study, which was a retrospective cohort study, the dose in two of the hospitals was empirically adjusted. So in one hospital, they increased it to double, so 5,700 units once daily. And in another hospital, they actually made that higher dose twice daily. And the primary outcome in this study was the cumulative incidence of thrombosis during their admission. Many of these patients, as I mentioned, are unfortunately still in the ICU. So what were the outcomes? So there was, when they looked at this, these patients, the cumulative incidence of thrombosis was 31%. And amongst these patients, 81% of them, so 25 of them, had pulmonary embolism as the event. Of note, 7 of these events were actually subsegmental events. And as we know, the significance of subsegmental PE in clinical practice remains controversial. There was 1 patient with leg DVT, 2 patients with catheter-related DVT, and 3 patients who had ischemic stroke. These were the independent predictors of thrombotic complications. So the main one was evidence of coagulopathy, so prothrombin time prolonged by 3 seconds, or an APTT prolonged by 5 seconds. None of these patients had overt DIC, and unfortunately, D-dimer levels were not explicitly covered in this manuscript that was just published online this morning. Something else I wanted to address, this was a case report in the New England Journal from 2 days ago, proposing that perhaps there was a connection between COVID coagulopathy and antiphospholipid antibodies. So this was a case of 3 patients in Wuhan who had sustained multiple ischemic strokes during their admission with COVID-19. And it was proposed that potentially there was a relationship between COVID and antiphospholipid antibodies. I will note 3 of these patients, all 3 of them had traditional cardiovascular risk factors. And the key thing about this study is that none of these patients had high-risk antiphospholipid antibody serology. So none of them had positive lupus anticoagulant serology. The anticardiolipin antibodies were IgA subtype, which has not been strongly correlated with thrombosis, and they didn't report antibody titers. And furthermore, this was not a persistently positive finding. This was a transient finding. And as we know, antiphospholipid antibodies can also be increased in the course of critical illness as part of the immune response. So in essence, there's no established association between COVID-19 and antiphospholipid antibodies or ischemic stroke that we know of to the moment. A couple words about the presumptive diagnosis and treatment of venous thromboembolism. So these recommendations are taken in part from the ASH website, which also has a wonderful guideline about COVID-19 as it relates to hematology. So if you are in a situation where there's a clinical suspicion for pulmonary embolism, but you cannot perform a CT pulmonary angiogram or a VQ scan due to isolation concerns or instability, clearly you would want to focus on what the clinical suspicion was and traditional venous thromboembolism risk factors such as cancer, prior history of VTE, hormonal therapy, etc. And then also any attempt to establish a diagnosis through an alternative modality would be strongly suggested. This could include bedside echocardiogram to look at RV function, bilateral compression ultrasound, or point-of-care ultrasound as well. When would you consider empiric therapeutic anticoagulation? So again, these are challenging cases and can be difficult, and these are difficult decisions. But in patients who have unexpected clinical or respiratory deterioration despite an overall clinical improvement in inflammatory markers and in chest imaging, especially if there's a high D-dimer concentration or fibrinogen level as evidence of hypercoagulability, this might be one situation when you would consider it. The second would be physical exam findings suggestive of thrombosis, so evidence of superficial vein thrombosis, calf swelling, a catheter or dialysis line-related thrombosis, or evidence of microvascular ischemia, so peripheral cyanosis, necrotic skin changes, those types of things. Again, this is an evolving area, but these are some general recommendations that are pragmatic and can be implemented in practice. Finally, let's talk a little bit about the evidence around anticoagulant prophylaxis. So this is a study, again from China, from Tang et al., looking at 450 patients who were admitted with COVID. So amongst these 450 patients, 40% had hypertension, 20% had diabetes, and 22% had an elevated what's called sepsis-induced coagulation score of greater than 4. Of these 450 patients, 99% of them received pharmacologic prophylaxis. That means that 350 of them did not. The doses that were used were enoxaparin 40 to 60 milligrams per day, which would be a standard prophylaxis or high prophylaxis dose, or subcutaneous and fractionated heparin at standard prophylaxis doses, and they looked at mortality at 28 days. There was no difference in mortality at 28 days between the heparin and non-heparin users. However, when they drilled down at the data, in patients, in the subgroup of patients who had a D-dimer that was greater than 6 times the upper limit of normal, there was a mortality reduction from 52% to 33%. And in patients who had evidence of coagulopathy by the sepsis-induced coagulopathy score, there was also a reduction in mortality with heparin as well. So there are challenges with this data, certainly. This is a retrospective study. It did not account for any other concurrent therapies that were being provided that could have also impacted on mortality. And in addition, it's possible that patients who received heparin prophylaxis, the 99 patients may have received it later as clinicians were gaining more experience with this disease. So it's a little bit challenging to know what to do with the D-dimer cutoffs and the data that's been presented here. So what to do with this data and what recommendations can we make at this time? You may have seen that there are some institutions that have protocols using intermediate or even therapeutic doses of low molecular weight heparin as empiric therapy in patients who have an elevated D-dimer or in patients who are admitted to the ICU. Again, these are empiric and are currently lacking in supporting clinical data, unfortunately. So we need more trials and randomized studies in this way. In general, all patients admitted to the hospital, ward, or ICU with COVID, regardless of their D-dimer concentration, should receive standard low molecular weight heparin prophylaxis, with the consideration for dose adjustment in patients who are of increased body mass index. And again, the efficacy of intermediate or therapeutic dosing based on the D-dimer, ICU setting, or mechanical ventilation is unclear at the moment, but generally not recommended outside of the clinical trial setting. Finally, I just wanted to highlight some interim guidance from the ISTH. This was a widely disseminated document from last week. They suggest in patients who are admitted with COVID that D-dimer, prothrombin time, platelet, and fibrinogen levels are drawn. Obviously, a judgment needs to be made about whether these patients are admitted to hospital. The one thing I would highlight is that because the D-dimer is a prognostic marker, it's been suggested that patients who have a level that is 3 to 4 times the upper limit of normal, some consideration should be made to admitting them to hospital and starting them on prophylactic low molecular weight heparin. Obviously, there are resource constraints around this that need to be considered on a hospital-wide basis. And the other thing that I'll mention is that there were specific recommendations around platelet transfusion thresholds and fibrinogen levels in patients with coagulopathy. The cutoffs that were mentioned here are not evidence-based, and I do think as inpatient and emergency physicians and hematologists, we need to really think about the blood bank resource implications that are involved. So again, back to our main messages today, severe COVID infection is a hypercoagulable state. although again, the prevalence of acute VTE at this point remains uncertain. Elevations in D-dimer are frequently seen, but may reflect an underlying pro-inflammatory or hypercoagulable state. And finally, in all admitted COVID patients, they should receive standard weight-adjusted VTE prophylaxis. And anything beyond this in terms of intensified prophylaxis regimens in specific groups, high D-dimer, ICU, mechanical ventilation would be in the context of a clinical trial. Thank you.
Thank you very much, Eric. That was a tremendous summary under great pressure with the evolving data coming out on this rapidly changing topic. Our next speaker is Deepa Suryanarayan. Deepa is a division head and associate professor in the Division of Hematology, Department of Medicine at Dalhousie University in Halifax. And she is going to be talking about managing your thrombosis patient remotely in the COVID era, a hematologist perspective, but I think this is also highly relevant to my colleagues in primary care. Deepa?
Hi, everybody. Good afternoon, and thank you, Alan, but I'm not the division head. I wish I was, but not. No worries. So we're going to be switching gear a bit here because we did talk a lot about the acute care of COVID patients, but we will be I will be mainly focusing on managing our thrombosis patients remotely in the COVID era, and this is equally important. If there is one thing I totally believe that this pandemic has done is that it has seen all healthcare systems move towards more innovation and the way we deliver care across all countries. But it certainly comes with some unique challenges of its own. And in terms of the outpatient management of thrombosis patients in this COVID era, we do have still a general responsibility to ensure that the anticoagulant care does not contribute to the burden of hospital healthcare system. And of course, we want to try and prevent ER visit as much as possible for patients with acute VTE. We also have a responsibility to continue to keep our patients on anticoagulation as safe as possible. To achieve that, we have to change the way we deliver care, utilizing unique local solutions while aiming to protect our healthcare resources in the best way possible. In order to discuss this, I have categorized them into three main areas. One will be management of newly diagnosed patients who are otherwise clinically stable with acute VTE who require initiation of oral anticoagulation therapy, and then the patients already on anticoagulation, specifically on direct oral anticoagulant agents, and the patients who will be on warfarin, which will be covered by my co-speaker, Dr. Shivkumar. Focusing on the patients who are requiring initiation of oral anticoagulation, and these will be your clinically stable, diagnosed with an acute PE or a DVT. And in this setting, ideally anticoagulation therapy should be initiated by clinicians in primary care with experience in managing anticoagulation. But we do have a lot of resources available even through Thrombosis Canada, and certainly you should be seeking any guidance by telehealth or phone specialists where needed, as they will be accessible through the pandemic. Where possible, try to move to remote consultations to initiate anticoagulation therapy, and also ensuring that we are arranging a phone follow-up for these patients. Where possible, definitely the shift is to start these medications such as direct oral anticoagulants where possible, and if there are no contraindications, instead of warfarin, to minimize the need for ongoing monitoring. And in these cases, possible choices could be rivaroxaban or apixaban, which don't require a lead-in with heparin. In terms of patients who would not be otherwise a candidate for a DOAC, such as you think cancer patients with GI malignancy or GU malignancy, or mechanical heart valves, consider low molecular weight heparin, again considering that we will need to find around and work around ways to educate the patient in terms of self-injections. If warfarin is the only choice and the monitoring is not possible, consider again low molecular weight heparin for a brief period with certain modifications for monitoring, which I know Dr. Shivkumar will touch upon in his talk. Try to provide prescriptions for 90 days where possible with utilizing electronic prescriptions or maybe directly to your community pharmacist. This can be a challenge because I know that, certain pharmacies may dispense it just 1 month at a time, just in the anticipation of any potential drug shortages. So it will be imperative for the local pharmacies to be aware of likely increased use of these medications. The other question, of course, is going to be coverage in this setting. And certainly, we may have to call upon the provincial pharmacare plans to consider covering for a DOACs given this unexceptional situation and the healthcare crisis. In patients who are already on anticoagulation, let's say they are on a direct oral anticoagulant agents, first thing to assess is anticoagulation still required in some of these patients? These could be patients who have been on direct oral anticoagulant agents with a provoked event, or whom you deem to be at a low risk for recurrence. Certainly, again, follow up, utilize all your options for remote monitoring, such as telehealth visit, video or telephone visits for ongoing follow-up. Again, this is the common thing that we need to be doing anyway in these patients. During each follow-up, inquire about bleeding symptoms, check for drug adherence and complications and any potential drug interaction which may arise. In terms of lab work that is required for monitoring, avoid any repeat labs if previously stable, because unless you think this would have a significant impact on your clinical management of this patient. What do you do in terms of what education could we give for patients to manage certain non-urgent bleeding issues? Encourage patients to avoid presenting to the emergency room for these minor cuts, bruises, and nosebleeds. There are certain tools that are available, which are also have a link on the Thrombosis Canada, the Michigan Anticoagulation Quality Improvement Initiative, which you could provide to your patients, which may give some information about how do you manage these common minor bleeding issues at home. Certainly seek specialist help should there be any concerns at any point of time in your patient care. What about the other situation where the patient is on chronic anticoagulation and goes on to be diagnosed with COVID, but a mild form of COVID which requires them to be at home, but not necessarily come into the hospital? We have to be aware of these unique other non-typical presentations of COVID, which include GI symptoms such as diarrhea, and patients may have decreased oral intake. This may have a role to play, especially if the patient is on warfarin, because as we all aware, this can affect your INR levels. In terms of the DOACs, likely has minimal effect unless the diarrhea is significant. And in patients who are on rivaroxaban, as we know, the risk of, if they do have decreased oral intake, the possibility of decreased bioabsorption if they do take it on an empty stomach. Again, things we need to emphasize as we follow these patients as our patient. So that's pretty much what I had as a spiel, and I will turn this over to Dr. Shivakumar to talk about VKAs.
So my apologies for introducing Dr. Suryanarayan with Dr. Shivakumar's credentials. So Dr. Deepa is in fact a clinical assistant professor in the Division of Hematology and Hematologic Malignancies at the University of Calgary. Our next speaker is Sudeep Shivakumar, who I will reintroduce as the interim division head and associate professor in the Division of Hematology, the Department of Medicine at Dalhousie University, to talk again about managing anticoagulants remotely from a hematologist perspective. Sudeep?
Thank you, Alan, and thank you, Deepa, for that talk. I'll be specifically focusing my talk on warfarin. Try and... There we go. Okay, so in terms of warfarin, as everybody knows, there are a lot of patients who are still on warfarin who require frequent blood work for INR monitoring. And the problem now, more than ever, is that patients are worried about the risk of getting blood work, requiring a trip outside the house when when everybody is saying that we need to stay in, and concerns about waiting for blood tests in areas where there's large amounts of people, exposing them to people who may have the coronavirus. it's caused a lot of stress and anxiety, but monitoring is something that you have to balance against the patient who is on warfarin, who is not getting any monitoring. And that would lead to an increased risk of complications like bleeding and thrombosis. I do take some solace in the fact that we do have some data to reassure us from perioperative studies where warfarin is interrupted for a period of 5 days to 15 days, depending on how long it takes to get re-anticoagulated around the time of surgery. And we do know that in atrial fibrillation patients, the risk of a thrombotic event during that time is low, but not zero. So in terms of ways to mitigate the frequent blood work that is mandated with warfarin use, I've listed some strategies, and knowing that every patient is different, it really is a case-by-case basis and how you address it with any individual patient. The first one I want to talk about is decreasing the frequency of INR draws. So really, this is ideal for the patient who is on a stable dose of warfarin with a therapeutic INR. In terms of a patient who is getting blood work, say once a month for INR monitoring, it would be very reasonable, especially in this situation, to extend that period. There is no guideline or rule as to the optimal duration or how long we can go without checking the INR, but just in polling the audience, polling colleagues across the country in anticoagulation clinics, decreasing the INR frequency to 8 weeks, 2 months, or 12 weeks, 3 months, instead of monthly or more frequent than that, seems like a very reasonable strategy to employ in these patients. And specifically, this might be more appropriate for patients who are deemed to be a lower thrombotic risk. And this would include the patient who has a venous thromboembolic event like a DVT or past the first 1 to 3 months, where you may think about letting up on very frequent INRs. Atrial fibrillation patients who have a low CHADS-2 score, and the low risk mechanical aortic valves, patients who don't have atrial fibrillation or a previous stroke or LV dysfunction in the setting of a mechanical valve. As well, although there's concern about going to a lab for blood work, the laboratories across the country are trying to make the laboratory experience as safe as possible. And the anecdotal feedback we've been getting from patients is that it's actually going very smoothly. And hopefully this is the same case across the country. There are less people getting blood work and less routine blood work being ordered. So waits are much shorter. And many labs across Canada are using scheduled appointments or time tickets to minimize patient exposures. Some provinces are employing strategies where patients wait in their car until their time and for their test, and then they get their test and go back to their car. Quebec specifically has CLSCs, or community health centers, which expedite the process of getting blood work. As well, there are alternate ways of monitoring the INR that can be used. Some pharmacies have point-of-care machines. These are pinprick tests where the result is the test is employed by the pharmacist. Some provinces have programs where the pharmacist can check the INR and adjust the dose, and some family physician offices have this as well. These point-of-care machines can also be purchased by patients, where they can do the INR in the comfort of their home and then have guidance from somebody over the phone for warfarin adjustment. The machines are not cheap. They're a few $100s, and really it's the test strips that can get you. It's the test strips that are very expensive, and this is not covered, so it may only be appropriate for select patients, but just something to think about in your arsenal of tools that you can use here. And then Switching to a direct oral anticoagulant should be considered. As everybody here knows, direct oral anticoagulants are approved for the management of DVT and pulmonary embolism, as well as stroke prevention and atrial fibrillation. And we do have 4 available in Canada: dabigatran, rivaroxaban, apixaban, and edoxaban. There is no routine lab monitoring needed for these drugs. And for the treatment of acute DVT or PE, there is the benefit that rivaroxaban and apixaban do not require a run-in phase with low molecular weight heparins, so they can start the oral medication on day 1. Now, the cost of these drugs is the issue, and as we all know, across the country, provincial pharmacare programs do have specific criteria for coverage of these drugs. However, I've heard from a few provinces. I saw that Alberta is making some changes in this time, according to the chat, and I know Nova Scotia is as well, where they would consider approving DOACs if COVID-19 is used as a justification. So the fact that we are trying to minimize blood work in all patients. Finally, I just want to say a few words about managing warfarin and DOACs remotely. The risk of bleeding is less than 2% per year. Again, you know, it's a low risk, but not zero. And we can check in on patients by phone and ask about bleeding complications, compliance, side effects. And as Deepa mentioned, we have to really be aware of drug-to-drug interactions, especially if a patient is starting a new medication. I would also like to say that high INRs on warfarin are a common source of phone calls to the healthcare practitioner, but they may not need intensive interventions. A high INR, less than 10 by some guidelines, can be managed by holding warfarin alone, as long as the patient is not bleeding, and vitamin K does not need to be given. So in these cases where a high INR is found, it is usually not necessary for the patient to have to come to the hospital in most cases. If they're bleeding, of course, that's a different story. So hopefully those are just some practical tips on managing warfarin in this time. And I'd like to thank you for your attention, and I'll turn it over to Dr. Lang and Dr. Bell.
Great talk, Sudeep. Really relevant to primary care and other non-thrombo physicians. So thank you very much. Our next talk is going to be from Dr. Eddie Lang. Eddie is professor and department head for emergency medicine at the Cummings School of Medicine at the University of Calgary. Eddie, I'll turn it over to you.
Thank you very much, Alan. Is everybody able to hear me?
Yep.
Great. Well, it's a real honor to have the opportunity to close down this presentation and loop things around back to the emergency department. There's so much we can say about the emergency department or response to COVID. I'm just going to focus on a few things that I think would be relevant to a general audience. I think one of the things, and I'll echo Alan's comments at the beginning, I think we have to always recall how difficult COVID is for healthcare providers, and I mean all healthcare providers. I put a story in the chat window from the CBC today indicating that 600 providers in Canada have been affected by COVID, and we really have to tip our hat not just to the action-packed emergency care and frontline providers, but we know from Italy that it's really all ranges of healthcare that are affected, whether it be primary care physicians and others who are taking care of COVID patients. So a salute to the heroism in our community. So if I have to talk about one primary thing, it's captured in this New York Times article where have all the heart attacks gone? We have seen, and this is an international phenomenon, a dramatic decline across the board in acute care health utilization. And that is translating not only to fewer people coming to hospital, perhaps because of fear of COVID, but it's also fewer EMS transports, fewer admissions to hospital, and as a result, we are seeing unprecedented levels of capacity in our healthcare system as we await the next phases of COVID. Even the Asian and European hospitals that are quite busy with COVID are still seeing a dramatic drop in other kinds of presentations. So what does this mean from a venous thromboembolism perspective? Well, one thing we can consider, and that we've heard anecdotal evidence about, is that people are delaying their presentation. They are coming to hospital with more severe disease, and their DVTs are much more extensive. Their PEs have been ongoing for several days before they sought medical therapy. So I think that's one thing we have to keep an eye out on. But we also have to bear in mind that the changes to the healthcare system have reduced the amount of provocation or provoked VTE that we are seeing. So clearly our orthopedic trauma is down, our elective surgery is down, and thanks to Deepa's advice, patients presenting with bleeding are on anticoagulates is not happening as well. So some very intriguing and fascinating trends. Here in Calgary, we've seen a 36% drop in all of our volume, and we think that part of that is the fear, as I mentioned, but it's also a change in the health status of the population. We've seen essentially the eradication of influenza, which usually lingers well into the April month, but has now, as a result of the social and physical distancing measures, disappeared. And we're looking at this more closely to have a better handle on it, but I think you'd probably agree that all acute care presentations are down. So it's as a result of this data that Eric was referring to, that we are now incorporating D-dimer in the evaluation of patients who are coming into the hospital as to help us to guide intensity of care and who may be walking that fine line between an intensive care and a regular ward admission, showing this clear, worrisome correlation between those at higher risk for non-survival and their D-dimer level and those who are surviving. I bring this photo up because it was done as part of a rule-out appendicitis examination, and it speaks to some of the diagnostic challenges we face in the emergency department. My colleagues in Switzerland have called this situation a COVID bomb. So essentially, we had a patient coming into the emergency department with no complaints of dyspnea, no cough, no clear risk factors for a pneumonia or COVID exposure, underwent a CT scan for a suspected appendicitis, and what turned out was that although they were in the non-COVID section of the emergency department, they were actually suffering from COVID infection. So the COVID bomb and the COVID chameleon is something that's certainly placing up a challenge for us. I think I'm only going to show you one more slide. There's a mountain of information coming to us related to COVID. One of my more favorite ones is from MD Calc. It's the COVID-19 Resource Center and includes some very valuable, rapidly evolving tools, including the Brescia COVID Severity Scale, which helps provide direction on oxygenation and appropriate ward placement of patients with COVID pneumonia, including resources that speak to some of the really unique things that we've never seen before related to permissive hypoxia and the uncanny fact that some of these COVID pneumonia patients are sitting with saturations in the 70s and 80s and are not even reporting dyspnea. So I'll close it up there with some finishing thoughts. The delayed and atypical presentations are prominent. We've completely seen a different approach to emergency care with such lower volumes of patients coming to our door and reduced injury and trauma and surgery. The D-dimer elevation is clear, as is the link to DIC and possibly even to thromboembolism. Thank you very much, and turn things back to Alan.
Well, thank you very much, Eddie. That's a real whirlwind view of what's going on in the emergency department, and you know, you're out there in the front line. So thank you very much for manning that important aspect of our care of our patients. I would like to take this opportunity to thank all of the participants. I would also like to thank all of the speakers. We will be repeating this seminar again in a couple of weeks. Thursday, April 23rd, 2 p.m. Eastern Time, we will be doing this session again. Feel free to register again. I suspect 2 weeks from now, we are going to see some new information that we will hopefully be able to present to you at that time. Please advise any of your colleagues that may be interested in participating to join in as well. So thank you all once again, speakers, participants, everyone. And I also want to take this opportunity to thank our sponsors, Bayer Canada, BMS, Pfizer Alliance, Leo Pharma, Novartis Pharmaceuticals, Pfizer Canada, and Servier Canada for their unrestricted grant, truly unrestricted grant of this program. So thank you very much, and good afternoon.